So we've talked about defibrillation cardioversion, and there's one more possibility that of an intervention that we can do with our defibrillator, and that is pacing. In this case, we're obviously talking about transcutaneous temporary pacing. So this is something that would potentially help us stabilize a patient before an intervention that is more permanent. For example, the patient getting cardiac surgery or some sort of an implantable pacer. So why would you need to pace a patient? Normally, it is a patient that presents with a bradycardia and who is in hemodynamic compromise. So a patient who is bradycardic and who has good neurological status and his hemodynamic values are good would not necessarily be paced. Another type of pacing could be done to override an abnormal cardiac rhythm. For example, certain types of paroxysmal ventricular tachycardia could be overridden, or atrial fibrillation can be overridden if we provide an impulse that is stronger what the atria initiates in a patient. So that would be another reason to pace a patient. In emergency situations, normally we would pace a patient who is bradycardic and hemodynamically compromised. So if we look at the monitor, this patient has a heart rate of 35, which is very low. His blood pressure is low with a mean arterial pressure of about 40, 41, which is a lot lower than the ideal 60, 65 millimeters mercury. So this patient would be a good candidate for pacing. Obviously, we would also assess his neurological status and the presence of pulse. Let's say my patient's neurological status is also compromised, so this patient would need emergency pacing. To pace, I will use my defibrillator and I will use the pads. We can't really pace a patient with paddles because you need to be able to step away from the patient. So the pads are applied in a defibrillator and monitoring position right now, in defibrillation and monitoring position right now. You can pace the patient like this, but this is not an ideal placement for the pads. To have the most success in pacing, we should apply pads anteriorly and posteriorly, like this, to capture most of the myocardium with pacing. So I'm going to remove this pad, and I would get help to turn my patient and to place this pad on the mid-scapular line somewhere in the area of the third intercostal space. So it would be resting on the left side on the mid-scapular line, third intercostal space, instead of the right side as we do with defibrillation, cardioversion, and monitoring. Okay, so that would be the ideal position. If this is a true emergency, I don't have time to turn my patient, I don't have time to place these pads anteriorly and posteriorly, I can start pacing like this and eventually switch. That's also another option. I have made sure that my pads are connected to the defibrillator. I also have a 3-lead electrocardiogram that is done by the defibrillator going to my patient's chest. It's all connected. I also have a 12-lead electrocardiogram connected to the patient, and I am recording everything with my EKG, and the recording is done continuously, which is the best practice, so we can analyze our interventions later. I'm going to take a look at the monitor, make sure that the patient still needs pacing, and then together with the doctor, we will decide what is the best pacing amperage, so what is the energy and current that you should be giving to the patient to pace, and this information would be input into the defibrillator. So in this case, instead of turning the knob to defibrillation, I'm actually going to turn it onto stimulateur in French, or pacing in English, depending on which kind of defibrillator you have. This will... Okay, so now I'm capturing the patient's electrocardiogram, and the patient's heart rate is 35. Okay, I have two options now. I can pace synchronously or asynchronously. Best practice is to pace synchronously because, again, as you remember, there is In the patient's electrocardiogram, there is a space that is especially vulnerable if we deliver shock in that space. On a T wave, it's vulnerable to precipitating an abnormal heart rhythm that might be lethal, like, for example, ventricular fibrillation. So if I have the chance, I will say that I will pace synchronously, so I will make sure that's on. And what I'm going to do next is I have to set the frequency. So I can turn the knob to set the frequency of my pacing. It's right here. You can start, normally it's the doctor who will prescribe the pacing frequency. Normally we start anywhere between 60 and 70 beats per minute, but it might go up according to the prescriptions. The second thing that I want to set up is the amperage. So basically how much, what's the electrical current that's passing between the pads. And you can set it,
check pad.
You can set it up or down. Okay, I apologize. Normally you would start at about 50 and you can adjust it to achieve capture. So basically when a discharge from the defibrillator corresponds with a heartbeat that follows it. Now I'm going to set the current at which I will stimulate my patient. In general, I will start at about 50 milliamperes. And I'm sorry, this will ring a few times. I will set it at 50 milliamperes to start, and I will see if I have electrical capture. What electrical capture means is that after an electrical discharge is delivered by the defibrillator, there's a following, there is a contraction of the myocardium, so there's an electrical signal in the myocardium as well. So what you're going to see on your EKG is an electrical discharge like this, and then a QRS complex that follows it, which basically tells me that after an electrical signal by my defibrillator, we also have an electrical signal in the heart. The second thing that I need to look for is mechanical capture, which means that after an electrical signal delivered to the heart and the electrical signal propagating down the myocardium, I also have an actual physical contraction, because electrical capture does not necessarily equal mechanical capture. So what I'm going to have to check next is the patient's pulse. So I'll check, for example, the carotid pulse, and I'm pacing, let's say, at 60 beats per minute. So I need to make sure that I'm also feeling the carotid pulse at 60 beats per minute. Another important thing to consider when transcutaneously pacing a patient is some sort of analgesia and sedation, because as you can imagine, this is a very uncomfortable procedure, and it's quite painful to receive an electrical shock to the precord, to the chest at a frequency of 60 to 70 beats per minute. So normally we will make sure that the patient has an IV access, and we will make sure that analgesia and maybe sedation is prescribed.